So we are live in 3, 2, 1. Please start.
Present in over 70 countries, with 10,000 plus employees, 9 world-class manufacturing sites. Research-driven company with complex R&D capabilities. More than 500 qualified scientists, 13 chirally pure molecules, 5 biosimilar. First in India innovative products. MCure's mRNA vaccine Phase 1 trials have started with funding from Department of Biotechnology, Government of India. MCure Corporate Initiatives. M Gurukul, India's first mentor-mentee program for doctors. Uncondition Yourself, first of a kind revolutionary talk show on women's health. M Vidya, a knowledge enhancement series for nurses and paramedics, in collaboration with Symbiosis College of Nursing, with 12,000 plus paramedics across 3,500 plus nursing homes. M Diva, MCure in association with RSSDI aims to promise better women healthcare in India. AnemiaFreeIndia.com, an initiative of FOGSI and MCure to spread awareness about anemia in India. Stroke Care App, an app towards stroke awareness for patients. BreastfeedingIsGood.com, an MCure initiative to promote breastfeeding awareness in India. At MCure, science wins.
When was the last time you heard women openly talk about their mental and physical health? Menstrual disorder, diabetes, pregnancy and breastfeeding, depression, cancer, infertility and safe abortion? Don't remember? Well, that's because the stigma attached to such conditions has forced women to bear the pain in silence. Dismal statistics on women's health need to change. A difference cannot be made until they voice their opinions, put forth their stories, and together bring about a healthy change. Presenting Uncondition Yourself, India's first of its kind revolutionary talk show dedicated to women's health. A platform where we talk about their health issues and breaking taboos. Catch Namita Thapar in conversation with leading doctors and patients, sharing candid stories. It's time to speak up. Together we can raise awareness and create an impact. Subscribe to our YouTube channel for more such videos related to women's health.
Can we have the next slide session? A very warm welcome to all the respected dignitaries. I welcome you for today's live program on COVID-19 and women healthcare. This is a series of programs which kick-started on 1st of May, and it's going to continue for 7 days. So we have the second last day today, and it is under this visionary leadership of FOGSI President Dr. Alpesh Gandhi and the Herculean efforts put in by the Secretary General Jaideep Tank. So Dr. Alpesh Gandhi has his message for today's program. So as India faces a second wave of COVID-19, various measures have been implemented to combat the spread of SARS-CoV-2. The emergence of new variants have made the situation more difficult. Experts have advised the use of double masking to strengthen the fight against COVID-19, along with vaccination. Therefore, it is important for frontline workers to know all the aspects of double masking to make their patients aware of the preventive measures in crucial situations. And I think today's topic is one of those important to take care in these COVID situations. मंजिलें उन्हीं को मिलती है जिनके सपनों में जान होती है. पंखों से कुछ नहीं होता, हौसलों से उड़ान होती है. So with this, I start today's session. So we have chairpersons today, and we'll be having 3 different topics for which the eminent speakers are ready. May I now introduce and call upon the chairperson, first chairperson, that is Dr. Jaideep Malhotra. We all know that she is a very dynamic. We have seen as a dynamic president of FOGSI in 2018-19, and she has led numerous organizations to her precision and perfection. She is a professor at Dubrovnik International University, Croatia. She was the president of FOMS, President Is Ppe, President Aspire, President of Indian Menopause Society, President of the ISAR in 2019-20, Editor-in-Chief of Journal of SAFOG and SAFOMS, member of Reproductive Endocrinological Committee of the FIGO. She is an editor and co-editor of n number of books and has received many awards, out of which the Indumati Zaveri Award, Jagdishwari Mishra Award, Ethicon Fellowship, and the Corion Award stand amongst many of those. So I welcome you, ma'am. Good evening.
Thank you, Nilesh, and a very good evening to all of you. At the outset, I would like to really, with folded hands, thank each and every one of our healthcare workers, our doctors, and the whole organization who are actually selflessly and unrelentlessly working towards this COVID pandemic. It is extremely important that this pandemic has been with us for more than 15, 16 months now. But even the topics which we are discussing today, and when I'm going from one place to the other in the hospitals in my own town also, and in my own hospital also, I feel absolutely claustrophobic when I see that the healthcare workers, in spite of many classes, constant training, constant nudging, constant reprimanding, are not following the norms which we are going to discuss again. And I feel we doctors are also equally responsible for it, because if we are going to just turn our face around and just neglect, because how much can we keep on telling everyone? I think we firstly need to be the role models. We must know what has to be done. And then in our surroundings itself, each one of us has a responsibility to get it done. Then only we will be able, because we are already suffering the impact of our apathy and I would say in a way our negligence, because somewhere we need to understand that yes, we healthcare workers, we doctors, nurses, housekeeping staff have to be together. And the worst is the housekeeping and the bio-waste management people. To educate them is a major challenge. And I think after learning what we are going to learn today, implementation, because I always say knowing is not enough. We must do it. And we must actually apply it, because unless and until we apply, no amount of webinars are going to help us. And I'm really talking today as you can understand my pain as a hospital owner also. I have 2 hospitals, so I really understand what each one of you must be undergoing. But I think our struggle, we are just born to keep on struggling through our life and selflessly serving. So we must accept the fact and keep on doing that. And I want to congratulate Dr. Alpesh Gandhi and Team FOGSI for unrelentlessly discussing on various platforms the same things, and hopefully to reach out to as many as possible. So God bless you, and I hope we will get over this, which is not seemingly looking at, I can't see the end right now, but I hope we'll get over it very soon. So today we have some wonderful speakers, and I will be very happy to introduce our first speaker, Dr. Reshmi Sia, who is an additional professor of OBGYN at the GMC Thrissur. And she again is the national mentor of Lakshay, nodal officer for M&M review, and a scientific committee coordinator for TOGS. She has number of publications to her credit, and also has been very well awarded for her performances in the postgraduate courses, and also as in the Dakshin quiz. And quality is her area of interest. Reshmi, we are really eagerly looking forward to listening to your lecture. And I hope everyone is definitely going to benefit from this.
Thank you, ma'am.
Thank you, ma'am.
Shall I share the screen?
Yes, ma'am.
Yeah, sure.
Okay, okay. Just wait a moment. So, first of all, let me thank from the bottom of my heart the organizers of this program for giving me this opportunity to present a topic which is very relevant in the current setting. And we are in the midst of a pandemic. We say it is a second wave. We hope it is the last wave. And we think and we hope and we know that we will overcome it very soon. And for this, triage in emergency and waiting area. Earlier, during the first wave or 1 year prior, when we started having COVID positive patients, only the major institutions like medical colleges, only those hospitals which is COVID assigned hospitals, designated hospitals needed to think about the triage. But now, as the cases are increasing more and more, all the hospitals may need to be converted to, many hospitals are being converted to COVID designated or COVID care areas. And let us all think about how we can use the word triage in the emergency area and how we can effectively triage the patients also. So my session objectives would be, let us look at what is a triage and what are the facilities needed in a triage, and what to do from the last 1 year of experience of working in a COVID hospital, what to do when a COVID positive pregnant woman reaches the triage, and also when I will tell you about the Kerala, when our Kerala Federation of ONG, how we have come out with the clinical practice recommendation regarding triaging the patients. So what is a triage? Triage is the term derived from the French verb trier, meaning to sort or to choose. A triage should be an area which is easily accessible in the hospital where the patients first come, with containing a waiting room, then triage area, and it should also have a team. I have written team leader, but it should be a team which caters to the triage area. So triaging is the process by which the patients are classified according to the type and urgency of their conditions. So it is to get the right patient to the right place at the right time with the right care provider. So it is all the more important in the COVID situation, when a patient or when patients are coming and standing in queue or are coming in ambulances, you have to know which patient needs your immediate care, which patients can be sent home, or which patient has to be admitted. So these are the levels of triage. We will see what does triage. Triage levels have resuscitation, that is level 1. Then level 2 is emergent. Level 3 is urgent. Level 4 is less urgent. And level 5, non-urgent. So there are 5 levels of triaging. And ideally, in a triage area, there will be a color coding where there will be, these patients can be shifted. So again, looking at the categories of triage, we all know there are 2 types of triage. That non-disaster, there will be, whenever there is a multiple casualty in the disaster, that is called a casualty triage or a disaster triage, that will provide the most effective care for the greatest number of patients. In non-disaster triage, it provides the best care for each individual patient. So ideally, a hospital casualty should have a triage area. Every hospital, even if there is no pandemic, should have a triage area. So when you look at the COVID triage, it is a non-disaster or emergency department triage, but as the cases increases, it may need to be converted to a disaster triage also. So the primary objective of a COVID triage would be to identify the patients requiring immediate care, determine the appropriate area of treatment, facilitate the patient shift and primary assessment and reassessment, and also avoid unnecessary congestion. Actually, these 4 are the primary objective of all the triage in every place. And then would be specifically to provide information and referral to the patients and families, alleviate the anxiety. As we know, all the patients, they will be very anxious regarding their health. The family members will be anxious. So we have to alleviate the anxiety. Then communication to the first line treatment centers, second line treatment centers, if the patients are sent home, to the healthcare workers in the periphery. So this all should happen in the time. And in addition, for the investigation, there should be a COVID testing area for the COVID triage area. And there should also be a data entry and data reporting, because we are daily going through a pandemic, and so it is a pandemic crisis management we are looking at. So this is the COVID triage with COVID testing, data entry, and data compilation and reporting. So these are something which is additional from the routine triage area. So let us just briefly look at what are the levels of triage. Triage level 1 requires resuscitation, that is threat to life, where when the nurse, the time the nurse goes and sees, assess the patient, or the physician assess the patient, should be immediate. There should be no delay. The example like cardiac and respiratory arrest, major trauma. So this is in non-COVID area also. Seizures, shock, status aspect. These are the conditions which require a level 1 triage intervention. Level 2 is emergent potential threat to life, limb or function. So here also the nurse should immediately tend to the patient, and the physician should see the patient within 15 minutes. This is where when the patient is having a decreased level of consciousness, severe respiratory distress, chest pain with suspicion of cardiac event, or severe abdominal pain. Now, third level or triage level 3 is an urgent condition with significant distress. Here, the nurse, there should be only a minimum delay of 20 minutes, and the physician should see within 30 minutes. Here, where there is a mild to moderate respiratory distress. Level 4 triage is less urgent condition with mild to moderate discomfort. Here, the time can be within 1 hour, but even then, within 1 hour, the assessment, the management intervention should happen within 1 hour. Here, where the patient is alert, there is no distress, no cardiac distress, and all, we can say that the patient is in level 4 triage. Level 5 is non-urgent condition, no distress. Here, it could be more than 2 hours, but even less. There is no distress. Or here, when you think about the COVID positive patient, an asymptomatic COVID positive patient. But when we look at the pandemic situation, it is better we immediately deal with the patient and send them home or to the periphery. So remember, actually, triage is a dynamic process. You may think this patient is non-urgent, but suddenly the patient may collapse. So the urgency with which a patient requires to be seen may change with time. So the triage category also changes with time. And especially, we are seeing pregnant patients. So we will be seeing pregnant patient coming to the triage area. So they will be in labor. So even if the COVID is asymptomatic, COVID is actually not a problem for them. They are just COVID positive. They might be in labor, or they will be having an obstetric complication like hypertension. So they may come with eclampsia. So this again changes the triage level. And triaging should happen, that is, as soon as the patient crosses your door or coming through the room. It is called across the door triaging or across the room triaging. Actually, as you even have, when you look at the patient, you'll be able to, an experienced nursing officer or a doctor will be able to categorize the patient into the correct triage. So patient actually should wait no more than 5 minutes. We are saying you can wait for 1 hour or 20 minutes for assessment and evaluation and management. But as soon as the patient reaches the triage area, within 5 minutes, the patient should be triaged and categorized. And you have to think that you have to remember that the last person in the long queue may have the most serious problem. And the person who is looking absolutely okay may suddenly turn up into a triage 1 level. So if in doubt, and again, when you categorize, always remember, if in doubt about the category, always assign a higher score, higher triage. That is, avoid under triaging. Now let us see about COVID positive pregnant woman. So pregnancy, as we all know, is a potentially immune compromised state. So hence the ICMR guidelines have already, even in the initial time, the first guideline itself have put all the pregnant women into category B. The COVID positive patients are categorized into category A, B, and C. But Pregnancy, when the pregnant lady comes with COVID positive, she automatically comes in the category B. So when the patient comes to triage, if she is critical or sick, triage level 1, you have to waste no time, immediately shift the patient to critical care unit or a high dependency unit. If in labor, after a quick assessment, she has to be lifted to the labor room or OT. So if whenever the patient comes, a thorough history to be taken if time allows, obstetric history and also the disease history, the COVID history, when she was positive, what was the contact at all. Then COVID symptomatology should also be asked for regarding dyspnea, shortness of breath and all. A quick review of the record should be done. General and obstetric examination and should be done, and categorize the patient. So for us, pregnant lady, there are only 2 options, category B or category C, categorize. In Kerala, what we did was for Kerala Federation of ONG, for the ease of management. When we saw during the first wave, most of the patients were in category B. But category B, actually, not all category B patients, all pregnant patients were symptomatic or having any problem. Majority were asymptomatic. So we further classified this category B into, that is for our ease of management and also to know whether what category she comes to. We categorize them into B1 and B2. That means B1, B2, and then C with severe symptoms. So this is the categorization. Category B is the asymptomatic pregnant woman. Category B2, pregnant woman with ILI symptoms like fever, cough, rhinitis, sore throat, diarrhea, fatigue, or a pregnant woman with comorbidities like hypertension, diabetes, renal disease, liver disease. And category C, as we all know, with the red flag signs. So ideally, the categorization should be reassessed even after the patient is admitted to the hospital or referred back to a second line treatment center. It should be every 24 to 48 hours. The categorization should happen, and she can be categorized to B1 or B2, and also based on the symptoms and also the walk test. So these are the clinical stages. I'm sure everyone must have gone through this severity stages. That is mild, no breathlessness or hypoxia, and respiratory rate is less than 24 with a maintained SpO2 more than 94% on room air, and asymptomatic becomes or asymptomatic are called mild clinical disease. Moderate is where the patient is having dyspnea, respiratory rate is between 24 to 29, and SpO2 is 91 to 94% on room air, or the patient is having fever or cough. Severe, we say when the patient is dyspneic, hypoxic, respiratory rate is more than 30. Here, we have to be alert. SpO2 less than 90% on room air, and the pulse rate is more than 125, even with or without pneumonia. So this is how we classify the severity of the clinical stage. These are the red flag signs. See chest pain, breathlessness, drowsiness, hypotension, hemoptysis, or cyanosis. So red flag signs, when you see in a triage area, when the patient comes to you, immediately manage the patient, immediately admit the patient, treat the patient. So this is a 6-minute walk test also, with which we categorize, we recategorize. So 6 minutes walk, ask the patient to walk for 6 minutes. If the SpO2 fall less than 93% or there is a 3% drop, you have to see that she is compromised, or if the patient is feeling short of breath or lightheaded. So this is how we manage when the patient is, and we ask the triage area ideally should have all these charts put up. So even if it's a new intern, a new resident who is on duty, or a new faculty who is on duty, that new staff nurse is on duty, she should know which category the patient comes. So category B1, usually less than 34 weeks, asymptomatic pregnant lady, she can be sent home. After the initial assessment, she can be sent home for home quarantine for 17 days. And she should be asked, given a literature, patient information leaflet regarding monitoring of SpO2, get her a pulse oximeter ideally, or tell her about the walk test, report to the nearest health facility if the SpO2 is 94. I know there is a shortage of pulse oximeter and all, so we can even ask her to hold the breath, single breath test up to 50, up to 40 and all. And she should be advised to have a proper diet, ventilated room, and advise ambulation, not even if she's confined to a room, ask her to walk around the room, and if needed, contact the physician over phone. So this is what happens when the patient is luckily in a category B1 and less than 34 weeks. More than 34 weeks, we usually ask the patient to go to a second line treatment center or a COVID delivery point, and here the patient has to be assessed for a routine obstetric checkup, and ultrasound is there. If not there, has to be taken, and stress test, non-stress test has to be done. And if the patient is okay and if the thing is normal, she can opt for a home quarantine, and once she becomes negative, ask her to come, and again give her all this instruction, ask her to contact through phone or e-consultation. And near term, if the patient is more than 44 weeks, but near term, we admit the patient. Coming to the category B2, that is a symptomatic pregnant patient who is having the symptoms of COVID, or she is having a comorbidity. She should be referred to the second line treatment center. Basic lab test are done. She is admitted, and daily vitals and SpO2 monitoring is done. Daily walk test is advised, and if symptomatic, we may have to go for azithromycin and oseltamivir, where the treatment of obstetric comorbidities should be done. Since the patient is admitted and the patient, she's a pregnant lady, we start prophylactic heparin, and if the patient is stable for 3 days, we can consider home quarantine after 3 days, provided she is not near term. And if the patient is progressing to category C or increasing inflammatory markers or worsening symptom, she has to be referred to a higher center or a COVID designated hospital. So coming to category C, here with red flag sign, so then they are admitted in a COVID designated hospital and detailed history and examination. So this all happens, whichever triage area the patient comes, you have to decide where to go. And I'm sure the COVID management of a COVID positive symptomatic category C patient would have been already been done. And here also we give prophylactic heparin, all the lab investigations done. And these are the categorization. So this is done in the triage area itself. So mild, moderate, severe. Respiratory rate is counted less than 24 breaths per minute, and SpO2 more than 94, she is having mild symptom. Then moderate is 24 to 29, and SpO2 is between 91 and 94. Severe means respiratory rate, if ever it is more than 30, less than 90% on room air, SpO2, immediately shift the patient. So from the triage, what are the investigations we sent? On admission investigation are usually sent from the triage area itself to avoid delay, like complete blood count, renal function and liver function. CRP is sent, a blood sugar is taken, electrolytes, ECG if possible is taken, and pulse oximetry is done, and the SpO2 recording or at the time of admission is recorded. Even if the patient is sent home also, it is recorded in the medical records of the patient. Only if the patient is, it is clinically indicated, or after admission, we go for a portable X-ray, D-dimer, ferritin, LDH, CPK, the pro-inflammatory markers like procalcitonin, others, TROP-I, TROP-T, blood culture, and in worsening condition, we even consider a high resolution CT. So these are the pro-inflammatory markers. These are the markers. These are all these markers. These are all kept as chart in the triage area, so that even in a COVID designated hospital, especially, and all even in the second line center, because it should be there, because only if you know the levels you can categorize the patient. So CRP more than 100 should make you worry. D-dimer, again, there is a cutoff in third trimester. It is between 500 to roughly 3,300, and anything higher than 3,000, anything more than 1,200 in the first trimester may be cause of concern. Ferritin level is also important, more than 300, LDH more than 400, and absolute lymphocyte count less than 0.8. So also these are the inflammatory markers. So let us look at the essential prerequisites in a COVID triage area. The first and foremost is there should be a leader, a responsible leader in charge of the triage area. He or she may or may not be present in the triage area 24 hours, 24/7, but the person should be in charge, knowing everything that is happening. There should be an effective communication going through between the team members, between the administration, between the leader, and all the non-COVID doctors also. Non-COVID, there might be a non-COVID area also in the hospital, so there should be an effective communication going on. So daily everything should be put up, who is in charge, who has to be called, which phone number to access, so everything, and who is the medical officer, who is the nursing officer in charge. And now with the era of all this social media apps, that's WhatsApp and all, we have an effective communication going on between. Then connectivity is important. An internet, an active internet, telephone, and a public address system should also be functional in a triage area. And there should be systems in place like charts, protocols, which are displayed to avoid delays and also ambiguity in the management. Even if it is day one of the staff, they should know what to do. Then teamwork, because people may be changing. There will be new teams coming up after 1 week or after 10 days, or people may go on leave. They may have some, they may be incapacitated. They themselves may have some health issues. So there should always be a system in place so that everyone who comes, a new staff member who comes, will see all these protocols and can work without any, don't have any delay. And there should be an effective teamwork between doctors, nurses, the lab workers, and also the auxiliary workers. Here, each and every team member counts, because there is no actually a hierarchy in teamwork, because even when we are shifting a COVID patient, even doctors do all this, shifting the patient, taking the trolley, pushing the trolley, taking blood, everything, because there'll be only a limited number of staff. Then there should be an efficient administration with online frequent meetings. Actually, there should be a fixed time daily meetings to overall review all the processes. If anything is happening, to update the criteria and all. And there'll be always a readiness to manage a critical event. So these are the facilities which we feel should be there in the triage area. Monitors should be there, multi-para monitors, pulse oximeter,
Request the audience to just be online. Dr. Resmi should be joining in shortly. Dr. Nilesh, may I request you to kindly call Dr. Resmi?
Thank you, Dr. Resmi. Session.
Dr. Resmi, you're muted, madam.
Yeah.
Yeah. There was some problem with the net connection. I think there was some issue with the connection.
Now we can hear you, madam.
Yeah. I'm just just the last slide.
Okay, last slide is there. Okay.
Yeah. Can you see the slide? No.
Yes, madam.
Yeah, this is the last slide. So, so these are the facilities, and team building, a dynamic team formation should be there, and teamwork is of most importance. So these are my references: the COVID-19 guidelines of the Kerala State Ministry of Health and Family Welfare, Government of Kerala, then KFOG GCPR COVID positive pregnancy in May 2021, and also RCOG guideline. Thank you so much, and I'm very sorry for the technical glitch in between.
Thank you, Dr. Resmi, for this wonderful talk. I think triaging is as valid as it was 1 year back, and it's a very important part of treating COVID patients. Some aspects have been included as additional aspects during the course of this year, and we got all those aspects in a nutshell from your talk. Thank you for that. We'll be having discussion at the end of the session. Can we have the CV for the next speaker, please? Yeah. So our next speaker is Dr. Kasturi Donimath. She's a professor and HOD at KIMS Hubli and the president-elect of KESOGA 2021. She's the ex-general secretary of the KESOGA, that is the Karnataka State OBGY Association. She is the ex-treasurer of the same organization and ex-president of Hubli Dharwad OBGY Society. She's the co-investigator of international research projects, MCI inspector to many colleges all over India, undergraduate and postgraduate examiner at many universities. She's the chairman of general students and general activities of KIMS Hubli and chairman of graduation committee of the same organization. She is the TOT trainer and faculty at many state, national and international conferences. She has conducted many workshops, CMEs and conferences. So I welcome you, ma'am, with this all huge academic experience. Thank you for coming.
Thank you, Dr. Nilesh. And first of all, my thanks to our FOGSI President, Dr. Alpesh Gandhi, and Secretary, Dr. Tang, for giving me this opportunity. So today I'll be talking on the topic, very, very important topic, that is donning and doffing. I'll just share my slides. Are my slides seen?
Yes,
we are able to see, ma'am.
Just to go back. So in this era of pandemic of this COVID-19, the right practices are very, very important. That is, I'll be talking on donning and doffing. This is really, really very, very important aspect of management of COVID-19. So in donning and doffing, what we mean is wearing PPE kit. What is PPE? PPE is nothing but it refers to anything that is used to decrease the rate of transmission of infection or harm to the healthcare worker. So this PPE is used to create a barrier between the healthcare worker and the infectious agent. So by method of this donning and doffing, our aim is to reduce the risk of touching, transmitting any infectious agent to our workers and all the doctors. So it is at most important that every healthcare worker has the knowledge of PPE and how to wear it, that is how donning, and how to remove it, that is doffing. Everybody should be trained, retrained, and retrained. As you saw, just our chairperson, Dr. Jaideep Malhotra, was telling that she really feels claustrophobic when she sees the healthcare workers, sisters, doctors, like sometimes not wearing the PPE kit properly or not practicing this infectious protocols properly, where like it really was so scary. So they need to be trained, retrained, and retrained. Not just trained and trained, they need to be supervised whether they are doing it properly. So supervision of the process is also very important. As administrators or as the leaders, it is our duty to see that they do it properly. According to the Fair Labor Standards, which was established in 1938, it is the workers' right. So we need to train everybody in donning and doffing. Why prescribe standard procedures for donning and doffing? For appropriate infection control and maintain asepsis, and to protect our healthcare workers from contacting infection. So the components of PPE are the surgical cap, the N95 mask, outer gloves, either sterile or unsterile, inner sterile gloves, gown or all over, shoe covers, face shield, goggles. All these are the components of personal protective equipment. Now, we have to do this donning in a designated donning area. This donning area is outside the COVID ward or the COVID labor room or COVID OT. And before you go ahead with donning, the healthcare worker has to have adequate take food, drink water, to use the toilet, and wash your hands with soap and water thoroughly. Remove all the jewelry or any accessories, like if you have worn the wristwatch or if there is any wallet, all that has to be removed. All the accessories has to be removed. Then you change to the scrub suit. Now, I will go through the steps of donning. So this is prepared by our Department of OBG, KIMS Hubli. The steps are shown by our resident, Dr. Sanjana. She'll be showing the steps. So first and foremost thing, you have to do hand. So hand hygiene is very important. You should follow all the 6 steps of hand hygiene. Then wear the inner gloves, sterile gloves. Take the PPE coverall. See for any damages or any tears of this coverall. If there are no damage, then sit on a clean chair. Then start wearing by wearing the leg covers. First one leg, the other leg covers. Then the arms. So roll your arm into it. One arm, the other arm. Then zip up. Then cover it with the flap. Cover the zip with the flap. Now take the shoe covers. Sit with the legs apart. Put one shoe cover. Pull the shoe cover up to the calf muscle. If you have strings, tie the strings. In case if there is no string, if there is elastic, just put it and leave it on. The other leg, tie the string. Now you have to wear the mask, N95 mask. It is held like a cup in the hand. Then the string should be outside, both hanging outside. Then put this mask onto the face. First take the lower string and put it. Then take the upper string and put it. See to it that it is tightly fit and there is no leakage anywhere. Then take the hood and put it properly, bring it forward so that it covers the forehead and the cheek. Now put the face shield. Then if you need to tighten it properly. Then next wear the gloves. Sterile glove, we will be wearing it. And pull up this cuff of this gloves as up as possible so that it covers the maximum length of your forearm. So now you are ready with the PPE kit, and now you can enter the COVID ward or the OT or labor room. Next is doffing. Doffing is also equally important as donning. So for doffing also, you need to have a separate designated area. And in this, doffing is much more important. And you need to have two chairs, one dirty chair, other is a clean chair. So you should also label those chairs as dirty chair and clean chair. And you should have an assistant to be present who will be inspecting your steps. And also when you need alcohol rub or any disinfectant, they'll be providing it. But most important to see to it that your assistant will not touch your PPT at any time. So they should be away, but at the same time monitoring what you do. And during doffing, hand hygiene is a must, and it has to be performed at each and every step. So we'll go through the video of doffing. Okay. 1 second. Okay. First of all, your observer whom is there should observe your PPE kit, whether there are any damages, any tears, or whether there is extra lots of contamination. In case if there is any contamination, take a alcohol rub and wipe those areas. And first and foremost thing is do hand hygiene with the disinfect the outer gloves. Then sit on a dirty chair. After sitting, then slowly remove the shoe cover. Don't touch the lower aspect, just the upper one, and slowly remove the shoe covers. Okay. And discard them in the designated bin. Then again hand hygiene. I told you every step you need to do the hand hygiene. Then after performing the hand hygiene, you will be removing the outer glove. Pinch the glove, slowly remove it out from one hand and the other hand. See to it that you don't damage the inner gloves or contaminate the inner gloves when you are doing this. Again, after that, again perform the hand hygiene with all the 6 steps with the antiseptic solution. Then remove the face shield and put it in a designated bin for that. After removing face shield, again perform the hand hygiene with the 6 steps. Next, remove the hood. Just lift the hood and slide it back. Then after that, remove the flap which you have stuck. Then remove the zip from above down and remove the coverall. Just pull it at the back and then roll one hand out, roll the other hand out and roll down the leg by touching the inner aspect. You are not going to touch the outer aspect of the coverall, and remove it. And by touching the inner aspect only, roll it and put it in a biomedical waste in the designated bin. Again, after that, perform the hand hygiene. All the 6 steps have to be done. Then remove your gloves from outside in and dispose of in the designated bin. Again, perform the hand hygiene. And then, okay. And now, before you remove your mask, wear one more pair of sterile glove. Pull the cuff as high as possible over on the forearm and remove the lower string, then the upper string. Hold only the strings or the straps. Never ever touch the mask and discard it. Again, perform the hand hygiene Okay. Now sit on a clean chair, take a alcohol rub and clean all the external surfaces of both the shoes. Again, perform hand hygiene. At each and every step, after removing each one, you are going to perform the hand hygiene. Very, very important. Okay. Now you will remove this gloves. Now again, at the end, once again perform the hand hygiene with all the 6 steps. Okay. Now, before you go out, you should sterilize with your shoes by putting your legs on the sodium hypochlorite solution foot rub, and then you should take a shower. So wipe your shoes over a hypochlorite solution soaked doormat and then take a shower, and now you are ready after the doffing. So this donning and doffing is very, very important, and you should never neglect this. If you neglect, you are prone for infection for yourself and all the healthcare workers. So we need to train, retrain and retrain our healthcare workers in this COVID era for donning and doffing steps. Thank you everyone for a patient hearing.
Thank you, Dr. Kasturi. Dr. Nilesh, I request you to kindly take the proceedings forward.
Thank you, everyone. I think Dr. Nilesh is muted.
Dr. Nilesh, may I request you to kindly introduce the next speaker?
Yeah, sorry. So we have our next speaker, Dr. Manpreet Karthelya, and it's my proud privilege and pleasure to introduce her. She is the professor and HOD at Al-Amin Medical College and Hospital, Bijapur, which was very close by to my alumni BMMC Solapur. She is the chairperson of Young Talent Promotion Committee of the Karnataka Society of OBGY, vice president of Bijapur OBGY Society, member of IMA KSB, teaching experience of more than 23 years, and trained in advanced ultrasound at Mediscans Chennai. She has a certification in GDM, certified by Indian Menopause Society as well. So welcome you, ma'am.
Thank you very much. Thank you very much. Can I share my screen?
Sure, ma'am.
A very good afternoon, everybody. It's my proud privilege to be made a part of this webinar. I thank you all. I thank Dr. Alpesh Gandhi and Dr. Aarti ma'am and the whole of FOGSI. Thank you. Now, we've talked about everything, almost everything concerning COVID. And now that we have delivered our patient, or we have operated on her, and or we have, managed her conservatively and she's home and healthy. Now we have to take some steps so that this infection does not pass it on to another healthcare worker or to another patient who is going to be next occupying this bed or this labor room or this operation theater. So I'm going to be talking on COVID-19 infection prevention and control, fumigation and biomedical waste disposal, basically. Now, before I start with the steps and with the details, I would like to, just clarify some terms, because these are terms that we have, these are a few of these terms which I heard for the first time once this COVID came up, and I wanted to look them up, and we may, not have been aware of these terms previously. First is a HEPA filter. A HEPA filter is a high efficiency particulate air filter. It is a type of pleated mechanical air filter. It theoretically removes 99.97% of particulate matter, especially dust, pollen, mold, bacteria, and airborne particles, which are more than 0.3 microns in size. Of course, COVID-19 particle varies in size from 0.06 to 0.14, may not filter that out, but the other particles are filtered out. Then we keep hearing of positive air pressure rooms. Now, the operation theater where we take the COVID positive patients should be a positive pressure room. That means that the air is forced into this room and there is a passive outflow of air. So an active inflow and a passive outflow of air, giving a positive air pressure or a high pressure room. Now this maintains a higher pressure than that of the surroundings, and it protects the vulnerable patients from infections and disease, example bacteria. Now this especially keeps the MRSA and other such bacteria out of the operating theater. Then we are hearing of the negative pressure rooms. Now, negative pressure rooms, there is a passive inflow in contrast to the active inflow in the positive pressure room. There is a passive inflow and an active outflow. It's like putting 3 or 4 exhaust fans in one room. Now, the labor and delivery room should be a negative pressure room ideally. It is a type of isolation technique, and it traps and keeps the potentially harmful particles inside the room. Now, this of course raises the question that what about the healthcare workers who are working inside this negative pressure room? Yes, they are definitely slightly more exposed to the to a higher viral load, because we are not allowing these virions to go out of the room. But then that is where the role of proper donning and doffing and good quality PPE comes in. Now, I'll be talking about KV wipes. These are non-woven towelettes which are impregnated with alcohol solutions for hard, non-porous surfaces and for fixtures. Now, these claim that they kill the tuberculosis bacilli in 3 minutes, MRSA, HIV-1, HCV, and COVID-2 virus within 2 minutes. Now, then I want to just distinguish between cleaning, disinfection, and sterilization. Now, COVID-19 can potentially survive in the environment for hours or for days, depending on the type of surface. Whether these fomites have a role in spreading and how much role they have is still, a matter of debate. But still, we have fomites, we have COVID surviving on surfaces. Cleaning is done with ordinary detergent and water, just soap and water, and it helps in removing contaminants, dust, and organic matter. And this further will help the disinfectant to do a better job. So cleaning is with ordinary soap and water, a very, very important step ever since COVID-19 and disinfection has come into our lives. Now, disinfection is a process which involves the elimination of most pathogenic microorganisms, but excluding the bacterial spores. It is done on inanimate surfaces. And in contrast, sterilization is any process that removes, kills, or deactivates all forms of microorganisms, including the bacterial spores. So cleaning is soap and water, disinfection is with disinfectants, but bacterial spores are left behind, and sterilization removes even those spores out. Now, cleaning and disinfection. Now, because we want to prevent the spread of infection from one to another, now there is a special method which is recommended for the OT, which is going to be allocated to the COVID positive patients. In this, as you see in the pictures, the anesthesia machine, the diathermy, monitors, medical equipment, they are all covered with a plastic sheet. Wherever plausible and possible, this can be done to avoid leaving back any infected material on these machines. Now, the OT door should be sealed with a plastic sheet. A COVID-19 signage should be placed on the door, making the people aware from outside that they are going to be stepping into an infected environment. Minimum people should be allowed into the OT. The next door OT should be used simultaneously along with a COVID positive patient only in the case to save a life or a limb situation, and otherwise it should not be used preferably. And even if we are using it simultaneously, a level 2 PPE should be used in that OT even though the patient is COVID negative. Now there should be enough time between two cases in the COVID OT for the patients to be transferred to the recovery and also for the decontamination of surfaces, cables and equipment. Now, COVID OT or labor and delivery room cleaning and disinfection is done in 4 stages. Number 1 is the initial cleaning. Number 2 is the in-between cases cleaning. Number 3 is the terminal cleaning. And number 4 is the detailed wash down of the OT or the LDR. Now, the initial cleaning should be done every morning. No one should enter the OT or the LDR before cleaning. All the surfaces should be disinfected. The order of cleaning should be from the clean to the dirty area, from top to bottom, and from inside to outside. If soiling is there, then soap and water should be used before disinfection is started. We have to disinfect the antiseptic bottles, the trays, the sterile containers, scrubs, basins, taps, everything that we are able to rub and clean, we should be scrubbing. And keep the OT LDR closed for 15 to 20 minutes. The people who are doing the cleaning should be trained cleaners. They should be wearing the appropriate PPE, heavy-duty gloves, boots, N95 or a surgical mask, goggles, and hand hygiene should be practiced immediately after removing the PPE. Hand hygiene cannot be emphasized more, just like Dr. Kasturi Madam has emphasized hand hygiene for everyone involved in COVID-19 care. Now, the initial cleaning of the OT, we have to clean the floor and the walls with 1% hypochlorite. High energy UV lamp sterilization has been recommended. Surgical instruments, once they are used, should be collected in bins, which contains 1% hypochlorite or glutaraldehyde or surgitol, is aseptol, kept for 30 minutes and then washed for autoclaving. Now, the in-between cleaning of cases, a signage of wet floor should be put so that nobody walks inside. We have to keep the OT door closed. Dirty surfaces should be washed with soap and water. This should be followed by a 1% hypochlorite wipe or a 70% alcohol wipe. We have to clean and disinfect the tops of the OT lights, the BP cups, suction canister, tourniquets if soiled with blood or blood products. Wet mopping of the floor should be done, and mopping of the floor 3 to 4 feet around the OT table should be done with 1% hypochlorite. Now, the terminal cleaning of the OT or the LDR. Now, so first we did the OT preparation, then we did the initial cleaning, then in between cleaning. Now, at the end of the day, what do? We have to clean and disinfect the OT table, the surfaces, and the floor again. Clean and disinfect the OT lights, the ceiling mounted racks, high touch surfaces, spot check walls for cleanliness, clean and scrub the sinks and the surrounding walls, mop all the floors, including under the tables. Separate mops are used for different rooms. Sufficient disinfectant should be used to keep the floor wet for at least 5 minutes. And slippers should be washed with soap and water, followed by 1% hypochlorite applied for 10 minutes. Now, thorough cleaning and disinfection. Now, in between this, now this was obviously about the LDR and the OT, but we are also aware that we have patients whom we are discharging from our COVID wards, or we are discharging from our special rooms, and we need to disinfect those rooms too, and that is the terminal cleaning of those rooms. Thorough cleaning and disinfection is done after the patient is discharged. Cleaning person should be wearing full PPE as for everything else. The dirty linen should be put in a yellow double bag and labeled COVID-19. Cleaning should be done with detergent and water. Disinfection from the clean to the dirty area should be done, and clean all the surfaces of the room, the bed, the overbed table, the window sills, the computer, the TV. Now, mattresses and pillows should be kept in 1% hypochlorite and sunned for 2 to 3 hours to dry. The soiled mattresses and the pillows should be put or treated with 1% hypochlorite, double bagged in yellow bags and sent for biomedical waste disposal. Now, immediate surroundings of the bed should be done, and the bed should be made. The toilets should be cleaned in this order. Clean the floor, toilet taps, nozzles, sinks, buckets, mugs, tap knobs, and treat with 1% hypochlorite. So first we wash with soap and water, and then we treat with 1% hypochlorite. And we also clean the biomedical waste bins, the inner and the outer surfaces. And lastly, we do the detailed wash down of the OT. If it is a daily used OT, we do it weekly. And if it is a less frequently used OT, we are going to give a detailed wash down once a month. Now, along with this cleaning of the labor room, there is also some special treatment of the labor room equipment, which we should be doing. The fetal Doppler and the NST machine should be wiped with Cavi wipes before returning to the LDR. The ultrasound probes, we should be using covers for the ultrasound probe and also clean according to the manufacturer's instructions once the use is over. Now, what are the disinfectants which are recommended for COVID-19 disinfection? 70% alcohol, phenolic compounds like Lysol, vaporized hydrogen peroxide used with the help of vaporized hydrogen peroxide generator, and vaporized glutaraldehyde. Now, the last VHPG for hydrogen peroxide and glutaraldehyde, these come as no-touch technologies. Now, frequency of cleaning and disinfection in the COVID areas, flu clinics, wards, ICU, COVID lab, LDR, and OT. Floor, 1% hypochlorite. Keep it, the contact time should be 10 minutes, 3 hourly, and as and when required. Mops should be washed with soap and water, then soaked in 1% hypochlorite, and it should be done after every 240 square feet of the floor area is cleaned. Then high-touch surfaces like doorknobs, doors, and beds and tables around. If they are metallic, then 70% alcohol wipe. Keep the alcohol till it dries. It should be done every 2 to 3 hourly. Non-metallic surfaces, 1% hypochlorite. Keep it for 10 minutes, and this should also be done for 2 to 3 hourly. Then low-touch surfaces, that is walls and ceilings, 1% hypochlorite after soap and water, 10 minutes twice a week. Toilets, 1% hypochlorite, 10 minutes after every use. Biomedical waste bins, inner and outer surface should be cleaned with 1% hypochlorite, 10 minutes, and done every use, after every use. Biomedical waste bags, outer surface should be cleaned before discarding them for BMW. Now, telephone, computer, keyboard, bedside monitors, ECG probes, ultrasound machines, pulse oximeter, infusion pumps, ventilator exteriors, 70% alcohol wipes after every use or as frequently as 2 hours, depending on the nature of the article which we are disinfecting. Stethoscope, 70% alcohol wipes after every use. Thermometer, which should be dedicated to one patient only. It should be cleaned with soap and water, wiped with 70% alcohol, and it should be done after every use and kept in a dry holder. BP apparatus, cuff, detergent, and warm water, and it should be washed after every use. I don't know when it will dry, so probably we need to have 2 or 3 numbers at least in our LDRs, depending on the patient load that we are handling. Then injection and dressing the trolley, wiped down with 70% alcohol, cleaned daily and disinfected after every use. Wheelchair, 70% alcohol, cleaned daily, disinfected after every use. Stretchers, again, same. Clinical sample containers, 1% hypochlorite, keep it for 10 minutes and do it before sending it to the lab. Ice packs after every use with hypochlorite. Liquid waste kept in or treated with 1% hypochlorite for 30 minutes and then sent for treatment. And finally, we have the surgical instruments, which should be dipped for 30 minutes in 1% hypochlorite or acetol or glutaraldehyde, and then washed and sent for autoclaving. Now, what is the role of fumigation? Because now we have observed, at least I have in my hospital also, that we are simply fumigating, and sometimes we are still sticking to the old methods of fumigating with formaldehyde or chlorine or fogging with chlorine. Now, the WHO recommends that routine application by spraying, fogging, fumigation, or misting is not recommended for COVID-19 because of basically 3 reasons. Number 1, it is effective as a primary strategy in removing contaminants outside of direct spray zone. Number 2, the spraying causes irritation of the eyes, the respiratory mucosa and the skin and causes ill effects. And thirdly, it may cause further damage to the lungs of the patient. There are other options available. Number one are the NTTs, that is no touch technologies. These are used with chemical disinfectants like vaporized hydrogen peroxide. These are effective. And secondly, UVC radiation, not UVA or B, it is UVC radiation done through robots and drones. There are several factors which affect the disinfection used with ultraviolet lamps. These factors could be the irradiation dose, the wavelength of the UV that we use, exposure time, the lamp age, the room size, etc. And hence, it is still being advocated that these methods can be used as a supplement, but do not replace the manual methods. So this has been taken from Cleaning and Disinfection of Environmental Surfaces in Context of COVID-19, released on 15th May 2020 by the WHO Interim Guidance. These are the robots which are being used for ultraviolet rays, and this is the drone which is disinfecting the room. Hence, washing and wiping for COVID-19, yes, and fogging and fumigation, not as the only method. Washing and wiping, yes. Now, one more thing for the floor is that wet mopping of the floor should be done with a 3-bucket mopping. It contains a bucket with the solution, the clean solution. It contains a waste bucket and it contains a rinse bucket. And finally, when the mops are used, they should be dried in the sun and kept upside down for drying so that the whole of the water drains off. Now, this is a sad picture. This really is a sad picture. There is a new crisis which is coming out to the environment due to the tons and tons, millions of tons of PPE that we are discarding. So it's very important for us to know that how to discard the biomedical waste that we are creating. In trying to mitigate one problem, we should not be increasing the other problems to terrible extents. So the biomedical waste management is extremely important during this COVID-19 pandemic. The biomedical waste management is no different from the biomedical waste management of any other disease, but however, the material is definitely more effective and we have to take more precautions. Now the yellow bag, now I remember the yellow as yellow. Why I? Why me? We keep saying, why me, God, why me? So I say that why I? Y is for the yellow and I is for the infected. So yellow bags are for the infected materials. These include the items which are soiled with blood and blood products like cotton and swabs, the woven PPE and not the plastic PPE. Plastic PPE means the eyewear, the shield and the gloves. They should go into the red bag. The woven PPE, our gowns, our caps and our overall, that can go into the yellow PPE, yellow biohazard bags. The linen going into the yellow, microbiology and lab waste, culture, specimens, vaccines, blood bags, which are all going into the yellow bags. Now, red, whenever I hear the word red, I'm sorry to say, whenever I hear the word, the alphabet R, I remember the RIP, the RIP in COVID-19 times, really sad. Now, when I say R, I mean red, and when I say P, I mean the plastics. So the biohazard plastics are going to go into the red bags. The gloves, soiled or unsoiled, the IV sets, bottles, catheters, urine bags, and vacuum chambers. Now, blue, I have remembered this mnemonic, blue glue sticks. B is for the blue bag, G is for the glass, and S is for the sharps. Or you can also remember the name of the BGS Global Hospital, if you remember that. So in the blue bag, we put the glass sharps, that is ampules and vials, and W is for metallic sharps. Again, Y and me, W for Y, white, and me, M for metallic sharps. So in the white container, we put the metallic sharps. Remember that the glass sharps had gone into the sharps have gone into the blue and the metallic sharps have gone into the white. Now, it has been suggested by ACOG that all the placentae which come off out of a COVID positive delivery or a section should be sent for histopathological examination. Now, if at all we are sending now, it is not made compulsory as yet, but it is, yes, advisable because we need to know what is happening to the placenta and this COVID wave, the new COVID wave, the B1617 variant and the other more dangerous variants that are coming in. Now, this seems to be affecting our pregnant ladies very seriously, very aggressively in contrast to the first wave. So we need to be knowing what is going on to the placenta and hence to the baby. And we are sending all the placenta of the COVID positive patients for HPR. Now, in case we send the COVID positive HPR to the lab, which should be done in a yellow specimen bag. It should be double bagged, or it should this bag, the specimen bag, should be put in a bucket. It should be labeled COVID positive, and we should clean the outer surface of the bag as well as the bucket before sending it to the lab. Now, how to dispose? Now, remember that there are two people or two organizations which are responsible for the biomedical waste disposal. The waste from screening, treatment, management, and immunization of the COVID-19 patients. The segregation and pre-treatment of this waste is the responsibility of the healthcare facility where it is generated, that is our hospitals. And then the collection, processing, treatment, and final disposal is done by the Common Biological Waste Treatment and Disposal Facility. Now, origin of the waste, the COVID wards, waste classification, chemical disinfection and sealing, collection to temporary storage. This is all done at our end. And finally, transportation to the CBWT facility and incineration or high temperature treatment facility, that is by the facility. Now, this is my last slide. So the take-home message is that in cleaning and disinfection, the best practices during COVID-19 pandemic would be that it's a very good idea to either follow the CDC, the state, and the local public health guidelines. Clean surfaces with soap and water, very important, washing, and use registered disinfectants according to the label directions. Number two, we have to be careful when we are using disinfectants around people with asthma. We have to be careful with fogging, fumigating, and wide area or electrostatic spraying. And we have to be careful with UV lights or ozone generators. We do not let children or students to apply the disinfectants. We do not ignore the label directions. We do not start mixing and matching our own disinfectants. And we do not use unregistered disinfectants. The disinfectants which have been recommended by all the bodies have already been mentioned in my talk. These are my resources. Thank you and stay safe.
Thank you, Manpreet Madam. It was a wonderful talk, and I think a nutshell of how to sterilize and infection control, prevention and control of the infection. So I have a few questions for all the faculty, and I think it was overall a wonderful talk with all the faculties. Thank you, Jaideep Madam, for logging in the session as a chairperson. She had to leave because of some emergency, but the triaging part, the personal protective PPE, donning and doffing part, all were wonderfully covered. So there are a few questions which were asked. Many of those questions are not relevant to today's topic, but I think the expert faculty can take up these if they feel so. The first question is, how do you counsel about COVID vaccination, whether to go or not to go in a pregnant woman in the current scenario where Ministry of Health and Family Welfare has not approved both the vaccines right now for use in pregnancy and lactation? So how do we go about counseling? That's the audience question is there. I would like to mention here that this conference is super successful with 8,600 and more delegates registering. And right now the live registers, who are observing right now is about more than 1,000. So hats off to all the faculties participating in it. So can you please take up this question, any of you?
Okay, regarding this, though it is as per FOGSI and as per all the international guidelines, RCOG, ACOG, SOGC, FIGO, everybody recommends vaccination during pregnancy and lactation because COVID infection in pregnancy is much more dangerous than any untoward side effects of vaccination. because we don't have trial anywhere in the world. We presume it doesn't going to harm, but definitely it is much more safer than the disease per se. In pandemic, every woman is prone, and pregnancy is a category B, so she'll have a tough time. So it is recommended, but Government of India actually they have scheduled a meeting on 13th, I suppose, May 13th. So I think in a week's time, Government of India, the guidelines will be coming. But when you go to a government center for vaccination, I understand, and even I have talked to the other coordinators who are vaccinating, they tell they cannot vaccinate the pregnant woman and lactating woman because when they have to upload, it doesn't take a pregnancy and so at present, maybe for a short period, we are having that problem. Once there is a dialogue with the Government of India, the things will be clear.
One supportive question which everyone is asking, whether it should be Covaxin or Covishield. Which of the vaccines is better according to you during the pregnancy and lactation?
Both are equally good. Both are equally good. Both of them are not live attenuated, so both are equally good. Live vaccines are contraindicated, and since both are not live.
Yeah. So I think another question for again Kasturi madam is that PPE kits are, this is the audience question, that PPE kits are made up of plastic or polythene. Some are made up of cloth material.
Yes.
So which are better? Plastic material is better or cloth material is better? That's what the question is.
It all depends on what is available. But if you have to choose between both, I choose that woven cloth, which will be like you can wear it for a longer time. The plastic one, it is different.
Yeah, because madam, when we wear that plastic one,
it is very
within 1 hour we are drenched.
Yeah.
And then environmental problems, plastics, hazards.
We prefer the cloth one, but it all depends on what is available.
Yeah, so that is, I think, wonderfully answered. So the next question is related to that. How long one has to wear a PPE if it working in a non-emergency department, like not in OT, but maybe in OPD?
Yes, when we are asking them to wear in the wards, when we have made a 6-hour shift, but because we feel a person cannot sit more than 6 hours with a PPE kit. So here our local protocol, we make it as a 6-hour shift.
Yeah, we also have the same protocol, 6 hours.
6 hours.
Yes.
Actually, we also have that same thing. But we usually say 4 hour. Actually, ideally, it is 4 hour with PPE. After that, it is actually said to be not very good for the health of the healthcare worker. But practically, actually, we all have had to wear the PPE kit for more than 8 hours and all.
But we are not asking to wear more than 6 hours. 6 hours we have kept it as max.
Yeah. So the next question is to Resmi madam. What is the triaging? In the triaging, what has changed over 1 year time? We had a low risk, moderate risk, and a high risk category in triaging. Triaging of the staff was also there. Triaging of the patients was also there. What has changed, you feel, in the 1 year's time over this triaging part?
Actually, when we started this triage area, it was in the infantile stage. But now, because of the first wave, and then we had a remission, we could learn from our mistakes, because earlier we didn't have this categorization. Earlier, we didn't have an ultrasound machine or a chest X-ray, portable X-ray in the triage area, because we had to shift the patient to the COVID labor room and then take an X-ray if needed. We didn't even, with each case coming, we learned, and the triaging area has now evolved into a very strategically, actually very efficient area. But still, I feel with 1 year of the COVID pandemic, and now with this increasing number of cases, there is a COVID fatigue also among the healthcare workers. So triaging, but that is when we need to strictly adhere to the protocol also, because whenever there is a protocol, strict timeline, and also there is a very clear-cut instruction on what to do, the risk of having mistakes being created because of human errors will be reduced if you have all those systems in place. So we have evolved because these categorization and all came recently, because it was not needed earlier. During the last year, it was not that much needed because the cases were few. But as the cases started increasing, we had to triage, because not all patients, earlier we used to admit all the patients, all pregnant ladies, because they were category B, we used to admit them. But now we don't admit all the patients, we send them home, we triage them, we actually assess them, and majority of them we can send home with all these information leaflets, all these instructions, and entrust them to the peripheral healthcare workers. So that was what it was, what has evolved. I think now it has become more efficient.
Allied question to this is that in the general OPD, what care do we take, and what do we define? How do you define in the current perspective of mutations of the virus, double mutation? How do you define a high risk exposure? The high risk exposure definition, has it changed? Because initially it was said that sitting close by for more than 45 minutes was considered as a high risk exposure. What is the current definition? Anything related to that?
Actually, the high risk earlier, whenever we had an exposure to a patient, because from the beginning of the pandemic, we had instructed our faculties and the residents, everyone, to wear the maximum protection. That is, even when our colleagues in outside India used to say that they are not using N95 mask except for the aerosol AGPs, that is aerosol generating procedures, we used to insist on the N95 mask and a face shield. So from the day one till now, we have been looking at patients with N95 mask, face shield, and also the minimum PPE, that is the overall gown. So earlier, whenever we had an exposure with these patients, if there was no mask, with no face shield, and contact more than half an hour, 15 minutes, without mask, we used to classify them as high risk contact and ask the healthcare worker to go on a quarantine. But now 100% when we follow up, when we do the contact tracing, the healthcare worker is having a full PPE protection. Only if there is a PPE breach, we have we classify it as high risk contact. But now practically it is not actually that easy to send a health resource person to a high risk contact and let her or him sit for 7 days or even 8 days or even a 3 days quarantine. So actually we assume that there is no PPE breach, but actually now there is practically all of the healthcare workers, even the nursing assistant, even the trolley worker, everyone are correctly using the PPE after this 1 year. And now the cases are increasing. They are also very much aware. So I think there is not much of a breach. I feel the breach, even in a COVID area, the risk is not from the COVID area with all these protections happening. It is from a non-COVID or even an outside hospital exposure, which is making the healthcare workers more vulnerable.
Right. I think so. So because I too had suffered COVID in March, so the breach was not in the hospital, it was outside. So I think we are extra cautious nowadays in the hospital premises, and that's a good thing. But I think taking care of ourselves whenever we are with our family or our friends is very, very important in this scenario. The last question which I would like to take is 5:30 already, is for Manpreet Madam, is how do you sterilize the OT premises if you cannot use fumigation? So I practice usually IVF. So the question may be related to that by the audience, that how do you sterilize OT if you are not using fumigation? Madam, you are muted.
Yeah, that's what I've told in my talk, that fumigation actually is not considered an ideal method of disinfecting the environment. So it is basically wipes with alcohol wipes for the metallic areas and 1% hypochlorite for the non-metallic areas. Or yes, glutaraldehyde, or we have ready-made disinfectants, which are proven to be useful, and ultraviolet lamps have been used, but their effectiveness is not been proven as yet. So it can be used as a supplement to wiping and washing with soap and water. Even soap and water does a lot of the job, completes a lot of the job.
Right. So I thank all the faculty. It's already 5:33 now, and we summarize this session with good take-home messages from all the three faculty regarding triaging, the PPE kit, proper use of PPE kit, and sterilization and infection control in our premises. I think this was a very important talk today. Tomorrow we are going on to a panel discussion about case-based scenarios in COVID. But towards the end of this total sessions of COVID-19 and healthcare in women, I think today's session was also very, very important, that we remain prompt on our toes that COVID is not over yet. And all these three aspects are very, very important when we think of preventing transmission of COVID and taking care of our near and dear ones and our staff too. So I thank the respected faculties, Dr. Resmi Madam, Dr. Kasturi Madam, and Dr. Manpreet Madam for coming here and sparing their valuable time and knowledge with all the delegates. Thank you so much.
Thank you. Thank you. Thank you.
In the end, I would ask all the delegates to download their certificates. Can we just show it on the link? So the delegates usually on their screen can go and click on the right side of the screen. The download certificate column is there. So they can click there and download their certificate for attending today's program. Thank you so much.
Present in over 70 countries, with 10,000 plus employees, 9 world-class manufacturing sites. Research-driven company with complex R&D capabilities. More than 500 qualified scientists, 13 chirally pure molecules, 5 biosimilar. First in India innovative products. MCure's mRNA vaccine phase 1 trials have started with funding from Department of Biotechnology, Government of India. MCure Corporate Initiatives. M Gurukul, India's first mentor-mentee program for doctors. Uncondition Yourself, first of a kind revolutionary talk show on women's health. M Vidya, a knowledge enhancement series for nurses and paramedics, in collaboration with Symbiosis College of Nursing, with 12,000 plus paramedics across 3,500 plus nursing homes. M Diva, MCure in association with RSSDI aims to promise better women healthcare in India. AnemiaFreeIndia.com, an initiative of FOGSI and MCure to spread awareness about anemia in India. Stroke Care App, an app towards stroke awareness for patients. BreastfeedingIsGood.com, an MCure initiative to promote breastfeeding awareness in India. At MCure, science wins.
When was the last time you heard women openly talk about their mental and physical health? Menstrual disorder, diabetes, pregnancy and breastfeeding, depression, cancer, infertility and safe abortion? Don't remember? Well, that's because the stigma attached to such conditions has forced women to bear the pain in silence. Dismal statistics on women's health need to change. A difference cannot be made until they voice their opinions, put forth their stories, and together bring about a healthy change. Presenting Uncondition Yourself, India's first of its kind revolutionary talk show dedicated to women's health. A platform where we talk about their health issues and breaking taboos. Catch Namita Thapar in conversation with leading doctors and patients, sharing candid stories. It's time to speak up. Together we can raise awareness and create an impact. Subscribe to our YouTube channel for more such videos related to women's health.
Team, please go offline.
Yes, sir. We are offline.